Now, moving on to our next section, that is what are the changes we see in leprosy when there is long-term neuropathic changes in foot and ankle as these areas. As we know, this is eventually it affects mainly the nerves. If it has affected the common peroneal nerve, which can which can lead to drop foot, and with this drop foot, we produces some kind of equinus deformity, which could be even rigid eventually, and this actually further predisposes these injuries to multiple injuries during walking. There is a problem with the foot supination, and because the foot is in equinus, this could be even lead to increased pressures on the toes, eventually leading to ulcers over the type, usually over the toes. Or there could be another deformity due to neuropathy, as the muscles actually leads to contract, especially the intrinsic muscle of the foot. This could lead to clotos. So what is a drop foot? It usually results in the paralysis in the lateral leg compartments. We know that the common peroneal nerve over the neck of the fibula actually divides in two, that is into the superficial and the deep peroneal nerve. Deep peroneal nerves descend down anterior in the anterior tibial compartment and supplies mainly the extensors of the and the dorsiflexors of the ankle. But the lateral superficial peroneal nerve descends down into the lateral compartment and mainly supplies the peroneus longus and the peroneus brevis, which are the evertors of the foot at the ankle joint. So therefore, eventually the if common peroneal nerve is involved, this results in the loss of dorsiflexion and eversion. This means that the foot cannot be dorsiflexed, therefore the foot will remain plantar flexed and inverted. Usually, as I told you, it's commonly the damage to the common peroneal nerve. This leads to drop foot, that is, the foot is in equinus and inversion. Dorsiflexion paralysis, as I just told you, mainly because the deep peroneal nerve is involved. This results in a problem that patient is unable to the lift leg higher than the usual, because the foot is actually in the equinus position. Therefore, it has to kind of a lift leg more than the normal so that the foot can get enough clear space before it can clamp its patients can clamp his or her foot down again onto the normal ground. But as it is doing so, there is actually increased chances of getting injuries, especially because the foot is in equinus in an abnormal position. Therefore, usually the injuries occur at the toes. This could be minor lacerations, there could be toe problems especially, and then eventually this starts actually a cascade, that these, as there's neuropathy, there's no pain associated with these injuries, and eventually there could be bacteria seeping through these wounds and eventually formation of pus and ulcers, and which eventually leads to toe amputations and multiple other forms of amputations. So this is actually a problem, is that as there is no pain because there is neuropathy involved, therefore not only the muscles are paralyzed, joints are paralyzed, and they cannot function properly. There's actually the injury which is taking place is also painless. Therefore patient is unaware that he or she is having this kind of a severe problem or has had some kind of an injury, therefore leading to this kind of a situation. Usually they're associated with high stepping gait. The foot becomes stiff in equinus, because if it remains in equinus for a long time, eventually the joint contracture occur, leading to rigid equinus deformity. And this eventually leads to intractable foot ulcerations. As I told you, peroneus longus and peroneus brevis are also paralyzed. Therefore, they are the main evertors of the foot. And evertor paralysis leads to inversion of the foot. So the foot is in equinus and inverted. The foot remains inverted, foot becomes stiff in varus, and usually ulcers develop as well, because with varus, the lateral border of the foot is more in contact with the ground as compared to the medial border. Sometimes, initially, if it's a flexible equinovarus deformity, then this can be corrected with orthosis or corrective surgery. But once this goes past beyond, becomes rigid, then we need definitive surgical procedures to correct it. This with orthosis, like with Charcot-resistant orthotic wears, and this cannot be corrected when it becomes rigid. But flexible can be corrected and maintained so that the further damage is actually averted. Now, coming to the types of drop foot, this could be a mobile drop foot or flexible drop foot, as I told you. Usually this requires transferring the tibialis posterior tendon as the anterior compartment, lateral compartment is paralyzed. Therefore, the posterior compartment is working, so tibialis posterior tendon is actually transferred in place of tibialis anterior. There could be skeletal fixation of the transfer tendon, a circumtibial tibialis posterior tendon transfer, that is, this transferred by looping it around to the first ray. Or there could be tendocalcaneus lengthening or transfers of peroneus longus muscle. Now, depending upon tibialis anterior is paralyzed, we can either, if peroneus longus is working, we can transfer peroneus longus to tibialis anterior, or if peroneus longus is also paralyzed, we can transfer tibialis posterior to the in place of tibialis anterior. Next is coming the fixed foot deformity or the rigid equinus. Now, the rigid equinus is actually when the despite foot it cannot be brought back to normal, foot is in continuous equinus and examiner cannot push it back to normal. That is when it has become rigid. That is, the equinus cannot be corrected to the plantigrade foot. There's fixed equinus and equinovarus, and usually the option of choice is Lambron-Radius procedure. The Lambron-Radius device a triple procedure called as triple arthrodesis, in which actually there is fusion of tibiotalar, subtalar, and talocalcaneal joints, so that this actually results in a stable plantigrade foot. Now, because the muscle tendon, as it is a rigid deformity, therefore the tendon transpose won't really help. Therefore, we have to go for a bony procedure in form of Lambron-Radius triple arthrodesis. Now coming to another deformity which is called as claw toes. As the neuropathy involves sometimes the intrinsic muscle of the foot as well, if it is involving the posterior compartment, this results to specific kind of a deformity called, due to contracture of these intrinsic muscles of the foot, lead to claw toes. This condition is due to the plantar intrinsic muscle paralysis and is more common than drop foot. It increases the risk of plantar ulceration greatly. The one problem is the patient is unable to sense any injury and unable to sense any unusual or overloaded pressure areas. Plus, the problem is if you see this toe, this means that these areas are more in contact with the ground as compared to this area. Therefore, ulcer will develop over here and on the plantar surface of this area. Therefore, this will lead to increased ulceration and increase problems and complications. And that ulceration leads to further increase in chances of infection. Therefore, what are the different types of claw toes? There could be first degree, second degree, or third degree claw toes. Coming to what the first degree is called the mild. Usually there is no joint stiffness. Again, they are flexible claw toes. Tips of the toes get ulcerated only, and usually the long flexors to extensor expansion is actually the transferred. We know that the extensors are working fine, so they can be transferred back to the long flexor areas. Therefore, the claw toes can be prevented. This clawing of the toes can be prevented. Second degree is a moderate degree. It is some degree, to some amount is flexible, but it is to some degree rigid as well. There's actually interphalangeal joints have been fixed in flexion. That is these areas, that is proximal and distal interphalangeal joint. While the metatarsophalangeal joint, which is this area, is actually still flexible. This could be lead to proximal interphalangeal joint orthodesis. Distal interphalangeal joint may be orthodesis excised. As the metacarpophalangeal joint are not stiff, there some degree of tendon transfers can be done as well. Now coming to another third degree claw toes, this is actually a severe form of claw toe in which almost all the joints have actually achieved have gone into either a fixed flexion deformity or fixed extension deformity. If you see this is the distal interphalangeal joint, which is in fixed flexion deformity. Proximal interphalangeal joint is in fixed flexion deformity, and the metacarpophalangeal joint is in fixed extension deformity. So this is a third degree toe in which the deformities have actually developed into a rigid structure. Therefore, it requires treatment of all this deformity of fixed flexion of interphalangeal joint. Dorsal migration of toes has to be prevented. There could be fixed hyperextension of the metatarsophalangeal joint. and this could lead to, as you know, this is basically the problem is that the weight is getting transported in this direction and the toes are in this direction. This results in this kind of a plunger effect, that as the patient tries to move and goes into push off phase, this metatarsal goes ahead while the toes are going actually dorsally, this leading to increased stretching of the capsules in the metatarsophalangeal joint. This is what is a plunger effect. Therefore, sometimes either you need to do some kind of transmetatarsal amputation, that is this and amputation at this level, so that the whole, or probably some kind of orthodesis in which you orthodesis all the joints into one direction so that a plantigrade foot can be achieved. Because now it has gone to a stage where the simple tendon transfer will not help. As open adduction or metatarsophalangeal joint or surgical syndactyly could be formed, that is the fusion of these joints leading to surgical syndactyly formation. In this section, we have briefly touched about how the leprosy can affect our foot and ankle functions. We know that it can affect different common nerves, especially most commonly affected is the common peroneal nerve. If that is affected, it results in the loss of anterior compartment of the leg and dorsiflexors of the foot, leading to actually equinus or plantar flexion. And then if there is a loss of superficial peroneal nerve as well, then there is a loss of peroneus longus and peroneus brevis, leading to loss of eversion. Therefore, foot is usually in equinovarus and inverted. And this can be prevented because if tibialis posterior is intact, this can be transferred in place of tibialis anterior, and equinus varus deformity can be corrected, provided it's not rigid. Once it becomes rigid, then we have to go for a bony procedure in form of labral triple orthodesis. Then we have briefly touched upon the claw toes. We have briefly discussed there are 3 degrees: this mild, moderate, and severe. Mild is actually flexible. In moderate, all the interphalangeal joints are rigid, but metatarsophalangeal joints are still flexible. Whenever only in the mild cases we can do some kind of tendon transfer, that will transfer the long flexor tendons back to the extensor hood. But in moderate to severe deformity, we have to go for either orthodesis or rear resection so that the plantigrade foot position can be achieved. Keep watching sqadia.com. Thank you very much.